Thank you very much, and welcome everyone. Today is not only Grand Rounds, but it is also our Alpha Omega Alpha Visiting Professorship Day. And in honor of that, I'm so pleased to introduce our guest speaker who will be here with us all day today, Dr. Gregory Townsend, who's a friend and colleague of mine. Dr. Townsend was appointed Associate Dean for Diversity and Inclusion at the School of Medicine at UVA in 2014. He shares general responsibility for promoting the educational mission of the school and provides leadership, information, and counsel to students, faculty, and staff to facilitate a positive experience for all as part of a diverse community. He co-leads the School of Medicine's Diversity Consortium and Diversity Steering Committee at the University of Virginia and is a member of the Admissions Committee. He also sits on the university-wide Diversity Council. Dr. Townsend, a native of upstate New York, earned his bachelor's degree at the College of William and Mary and received his MD from the University of Virginia School of Medicine. After completing a combined residency here at WVU in internal medicine and pediatrics, he returned to UVA for a fellowship in infectious diseases and has been at the university since then. At the time he joined the faculty there, he was one of a handful of African-American faculty members in the School of Medicine. He is currently Associate Professor of Medicine in the Division of Infectious Diseases and International Health, Department of Medicine. Dr. Townsend's primary clinical focus is the care and treatment of individuals with HIV. From 1998 to 2020, he was Associate Director of UVA Infectious Disease Clinic, Director of UVA's Ryan White Clinic, and Principal Investigator on several federally funded Ryan White grants aimed at providing better care for patients living with HIV/AIDS. He has won numerous awards as a clinician and educator and was an inaugural member of UVA's School of Medicine's Academy of Distinguished Educators. Dr. Townsend's interest in diversity has really been shaped by his personal experience as an underrepresented minority in academic medicine and by his clinical interest in the treatment of HIV, a disease that has a disproportionate impact on racial minorities, the poor, and otherwise disenfranchised members of society. He has been a member of the School of Medicine's Diversity Consortium since its inception. It's my pleasure to introduce him, and I'm so grateful he was able to be with us today. Dr. Townsend.
Thank you, Dr. Fisher, and thank you again for inviting me to be here today. I am going to be talking to you about anti-racist medicine, but before I get into that, I have nothing to disclose. I want to talk to you about some people who have been very important in my life. Norm Ferrari. When I was an intern, Norm was my preceptor in the pediatric clinic, and I learned from Norm the importance of being an excellent bedside teacher, and also he has been my model as a bedside clinician. Rashida Kaku. When I was a resident here, Dr. Kaku led the morning report, and she both terrified and amazed me because she seemed to know everything that there was possibly to know in the medical literature. It was not uncommon that she would say something like, the July 1978 issue of the Singapore Journal of Paleoarchaeology. And I was like, what? Where did that come from? She was absolutely amazing. She also taught me the value of holding on to your car as long as that is possible, a lesson that I've taken to heart. And Melanie Fisher. Dr. Fisher is why I became an infectious disease physician. She was my preceptor when I was on the infectious disease consult service, but I had no interest in ID before I started. Her enthusiasm for clinical practice and for infectious disease practice in general was, dare I say, contagious, and is why I have entered the field of infectious disease. So I am eternally grateful to have had these three people and more from WVU in my life. A different set of faces. So I just want to let you know that it is entirely comfortable that some of the things that I will say to you this morning will make some of you uncomfortable, perhaps ashamed, perhaps angry, I hope not bored. And that's okay. If I haven't provoked some of those reactions in some of you, then either you don't need to hear what I have to say, or else I'm not doing a very good job of getting my point across. But I hope that you'll keep open ears and an open mind. So without further ado, here's what I'm going to talk about. First, just some definitions so we all know what we're talking about. A very brief timeline of some examples of either overt racism or subtle racism that have occurred in or have impacted medicine over the years. And I'm going to talk to you about how US medicine is racist, who we train, who trains those trainees, what we teach them, how we practice, what we fund, who we fund. And then finally, there's no point talking about this if we can't do something about it. And there are things we can do about it. And that's what I'm going to end up with. So first we need to talk about this. Everybody knows this, but we need to say it out loud. That race is not biology. Race is a social construct. These two little girls are twins. Same mom, same dad, same uterus, same prenatal environment. Most people look at them would say that the one on the left is white, the one on the right is black. If race was biology, this was not humanly possible. And this is not a matter of semantics. It's important because if we take race out of the biology equation, and some of the things that we do in medicine don't make any sense. Race was not a concept as applied to skin color until colonial era United States, when wealthy white landowners realized that if the poor whites and blacks who were working for them were to rebel, which they did, they would be in trouble. And so they made laws that differentiated blacks and whites. And that's where the concept of race comes from. So talk to you a little bit about racism. I'm not going to read that definition, but I don't want to talk to you about the different kinds of racism. So there's interpersonal, that's the kind that we're all familiar with, that occurs between individuals. Institutional is the racism that is built into our institutions, our legal systems, our banking systems, our education systems. And then structural racism is sort of the interplay of all those institutional racisms. Then there's cultural racism. That's the things that we see all around us in our media, in what we read and what we see online, and comments that are made about people. And then finally, there is ideological racism. Those are the worldviews and common sense ways of thinking that are normal, but are rooted in racial ideas. Ibram X. Kendi is a historian who has written a lot about anti-racism, was probably a foremost thinker about it, and has these definitions, what's really like. So a racist is one who supports a racist policy through their actions or inactions, or expresses a racist idea, whereas an anti-racist is one who supports an anti-racist policy through their actions or expressing an anti-racist idea. And I like this definition because it is actionable. There are some who will say that racism has to do with power, and I understand why people have that belief, and I don't have a problem with that. But my issue with that is that if racism is all about the color of your skin, well, there's not much you can do about that. You can choose to change your behavior, and I think that that's what racism is all about. Is what you do. And also, I think that it's important to note that this is a sort of a state definition. So the one can be racist, sometimes anti-racist, sometimes it probably can be racist and anti-racist at the same time, depending on what you're doing. But again, it gives you some room to move into an anti-racist stance. So again, brief timeline on sort of how we got to where we are. Obviously, it all starts here, right? Spanish explorers enslaving Native Americans within about 20 years of them arriving in the New World. Then the Spanish explorers enslaving Africans and bringing them to the New World. And then obviously in 1619, English colonialists enslaving Africans, and again, bringing them to the United States and then perpetuating that racism here on this continent. And it's important because not only obviously the institution itself of slavery being horrendous, and leading to the issues that we see today. But it also promulgated an idea that some people were not just inferior, but were really subhuman. It's hard to enslave someone that you think of as being human. And so if we can think of people as being subhuman, then we can treat them as being subhuman. We can treat them as we would treat other animals. And I think that's an important point. 1837, James B. Smith became the first Black American to earn a medical degree. but he had to go to Scotland to do this. Now, this is a smart guy. When he was 11, he was asked to deliver an address to the Marquis de Lafayette, who's doing a tour of the United States. He graduated from the University of Glasgow with bachelor's, master's, and medical degrees, and graduated at the top of his class with all of them, became a founding member of the New York State Statistical Institute. But despite that, he was not allowed into a medical school in this country. It'd be 10 years before a Black American graduated from a US medical school with a medical degree. Around the time that that was happening, J. Marion Sims, who's considered the father of US gynecology, developed his gynecological techniques by experimenting on unanesthetized enslaved women and their children. What he did with his children, so he thought that one of the reasons that, in his view, Blacks were not as smart as whites was that their skulls were too small and wouldn't allow their brains to grow. And so he would actually pry apart the bones of African children, again, without anesthesia, to allow their brains to grow. In 1895, the National Medical Association is formed in part because Black doctors weren't allowed into the American Medical Association. And then starting in 1907 and continuing up until the late 20th century, 32 states engaged in forced sterilizations, largely targeted at Black, Latina, and Native American women. And I want to read you a quote. This is from a European statesman from the 1930s. It says, "I have studied with great interest the laws of several American states concerning prevention of reproduction by people whose progeny would, in all probability, be of no value or be injurious to the racial stock." That was Adolf Hitler. Now, if Adolf Hitler is lauding your social engineering policy, there is something wrong with your social engineering policy. In 1910, Charles Flexner was asked to review US medical education and published the Flexner Report, which resulted in the sea change of how we educate medical students in this country. But among his recommendations, which was followed, were that 5 of the 7 medical schools in the country at that time that served primarily Black students be shut down. So only Howard and Harvard were left at the end of that. And again, I want to read you a quote. This is from Flexner. This is from the Flexner Report. "The practice of the Negro doctor will be limited to his own race. So the Negro must also be educated not only for his sake, but for ours. He has the tremendous importance that belongs to a potential source of infection and contagion." So Flexner's idea was that Black doctors should be trained so they can take care of Black patients, and Black patients needed to be taken care of because they were a danger to whites. 1932, everybody knows about the Tuskegee experiment. I put that in quotes because this wasn't an experiment, this was abuse. Over 400 Black males enrolled in the study with syphilis. Starting in the 1940s, penicillin was available and was known to be curative of syphilis, but they were not treated for their syphilis. And this went on up until 1972 and only stopped in 1972 because a newspaper got wind of it and leaked the story, and Congress shut it down. This resulted in more than 100 deaths, syphilis acquired by 40 wives, and 19 cases of congenital syphilis. Now, World War II occurred during this period, and again, we knew that penicillin was curative of syphilis around toward the end of World War II. There are about 200 inductees who were part of this experiment, and the U.S. Army did syphilis testing on all of its inductees once they had a penicillin. They wanted to treat these inductees, and the leaders of this experiment would not allow them to because they wanted to see, again, the natural history of syphilis. Now, a rejoinder to this, and something I am not at all proud of, the leader of the Public Health Services and the 2 assistant directors of the Public Health Services, the ones who initiated this this program, were graduates of the University of Virginia School of Medicine, because at the time, UVA was a leader in the eugenics movement, and these were all devotees of the eugenics movement. Around that same time, 1934, and this, it's not clear how this ties into medicine, but I'm going to talk more about this. But the Homeowners Loan Corporation, the Federal Housing Administration, started using redlining. For those who don't know what this is, but basically what they did was they would divide neighborhoods into zones, from green, which was sort of the best, to red, which was the worst. And your ability to get a loan for a house was determined on which zone you're in. And basically, if you were in a red zone, you weren't going to get a loan for your house. And if there are any Black people in your neighborhood, chances are your neighborhood was going to be redlined. So the neighborhood with Black people, nobody's going to get a loan for the house. So housing prices were going to be rock bottom. And also, as a byproduct of that, if you were in a neighborhood that was all white, you would not want Black people moving in, even if you were, not racist, because immediately housing prices were going to go down because of the inability to get loans because you're going to get redlined. 1949, the National Medical Association, which I talked about earlier, petitioned the AAMC to issue a policy basically saying that we're not going to discriminate, and the AAMC declined. It wasn't until this century that the American Medical Association and the AAMC apologized for their racist past. All right, so that's a little bit of how we got here. There's obviously a lot more to the story, but I just wanted to give you some of the highlights. So I'm now going to tell you about how US medicine is racist. And I want to start with this. I do not at all intend to mean that we, individual practitioners, are intentionally racist. I'm not even talking about unconscious bias, although most of us probably do have unconscious bias. I've taken the implicit association test and I have a pro-white bias, as do most physicians. But that's not what I'm talking about. What I'm talking about is that racism is such an integral part of our society that even with the best of intentions and the best of actions, it is almost impossible to practice, to teach, and to research in medicine without this being in some way influenced by racism. Here's our medical students. Almost 50% of our medical students currently in our classes are white. This is disproportionate to the number of whites in the society. More importantly, a very small percentage, so here are Hispanic and Latinos, here are Blacks, only about 15% of our medical students are what we consider to be underrepresented in medicine. Native Americans, you can't even see them right here. This population, so this is the sort of 25 to 29 year age, about 35% of our population are in this group: African American, Black, Hispanic, Latino, Native American, but only 15% of our medical students are in that population. And I'm not going to go over this item. I'll make these slides available for you because there are a lot of things that I want you to know, but I don't have time to talk about. But most of you probably know that there's differential attainment for our BIPOC students, Black, Indigenous, persons of color students. And there are lots of things that go into this. And again, I don't have time to go over all of this, but it is a continuum, and it starts with getting into medical school and everybody that these individuals will encounter as they get into medical school, ultimately resulting in fewer honors, grades, and awards. At our medical school, so I'm on the AOA selection committee, just recently, the last couple of years put on it. And it was decided when I got onto the committee that we should look at what percentage of our URM students or what percentage of our AOA students are URM. And over the preceding 10 years, that percentage was 0. Not a single URM student had been awarded AOA. And it turns out, and I just thought this was crazy, that basically our AOA selection process was sort of a popularity contest. The students actually got to, after knowing who was eligible, the students got to vote on who they wanted to be AOA. We changed the process 3 years ago so that we started looking at not only academic achievement, but also community service and leadership as the parameters for being AOA. And for the last 3 years, about 20 to 25% of our AOA students have been African American or Latino, which is about the percentage of those students in our class in general. Residency, the same thing. Again, Black, Native American, Hispanic, representing about 14% of our residents. Again, about a third of our US population represented by these ethnic groups. So clearly there is a disproportionate deficiency of our underrepresented racial and ethnic groups in our residencies. Does this make a difference? Well, it probably does. So this study actually came out of the University of Virginia, a few years ago. They did surveys of our medical students and residents to look at some of their preconceived notions about race. And they asked them about whether there are differences in all these parameters you see there on the right of the graph between white and Black students. And I just want to point out the green columns here. So this was skin thickness. And as you can see, a huge percentage of our students from M1 to M3 and our residents believe that there were differences in skin thickness between Blacks and whites. And this is important not only in and of itself, I mean, this is obviously a huge issue, but also this was reflected in our students and residents' perception about the need for pain control and whether or not they would, or to how frequently they would use pain control in managing patients. Who's teaching them? Well, these are data from the AMA. Our Black, Indigenous, and persons of color are, as I'm sure you know, severely underrepresented in our medical school faculty. Oops. What are we teaching them? So this came out of actually a student-led study from Brown University, where they looked at all the slides that mentioned racial differences from their preclinical lectures, and they determined whether or not the lecturers attributed those differences explicitly to biology, or at least implicit to biology, or if they actually mentioned that there were social and structural issues that related to those differences. And as you can see from this slide, only 4% of the slides mentioned that social and structural issues were contributors to those racial differences. The rest were attributed at least implicitly, if not explicitly, to biological differences. And again, race is not a biological construct. So some of the things that have contributed to misrepresentations of racial differences in our curriculum are semantics. So using words like Caucasian to denote biological differences, describing a person who's from Africa as African-American. I have heard that happen in my presentations from students. Again, as reflected in the previous slide, teaching about racial differences between Blacks and whites, or between other minorities and whites, without reference to the social determinants of those health differences. Talking about race-based diagnostic bias, presenting links between racial groups and diseases, like talking about sickle cell disease as a disease only affects Black people, when in fact it affects anyone who comes from a population that was at risk for malaria. Pathologizing race, so linking minorities with increased disease burden. The one slide showing there are 13 types of brain tumors in Black and white patients, and the titles of the slide saying that the incidence of these brain tumors is higher in Blacks than in whites, when in fact the incidence of most of them was higher in whites. And then using race-based guidelines, and I'll talk more about that. So dermatologists, they talk about skin all the time, right? So you would think that they would be sort of up on this. So this is a study on the COVID era of 116 images from articles describing cutaneous manifestations of COVID-19 infection. You can see on the right side, those are images taken from those articles. So for those of you who don't know, and I didn't know this, but dermatologists have a scale for skin color going from 1 to 6. And basically 1 to 4 is white, and then 5 and 6 are darker skin colors. Only 6% of the slide showed anything resembling a dark skin patient. And of the patients for whom race and ethnicity reported, the vast majority were white or Hispanic. These same authors did an analysis of some dermatology textbooks to see whether or not there was disproportionate representation of whites in those textbooks, the 2 textbooks. And they found actually that the representation of dark-skinned people was appropriate to the population in those textbooks, but with this caveat. They found that somewhere between 50 and 60% of the images that represented sexually transmitted infections were among dark-skinned people. And I looked it up just to be sure. That is a gross overrepresentation of sexually transmitted infections among people of color in the United States. So although the overall representation of persons of color was appropriate, that was skewed by an overrepresentation among sexually transmitted infections. So not surprising that a student would be more likely to think about a sexually transmitted infection and less like in a Black or other brown skinned person, and less likely to put that in the differential diagnosis for a white patient. You probably know this, but significant health disparities exist in just about any field that you can think of that has to do with our patient care. And that people of color receive less interventions, procedures, again, across the board. No matter what you think about it, people of color are getting less of it than the white counterparts. About 20 years ago, the Institute of Medicine published this monograph, Unequal Treatment, and found that evidence of racial ethnic disparities are remarkably consistent across a range of illnesses and healthcare services in the United States. And importantly, that most of the studies found that those differences remain even after adjusting for socioeconomic differences. So it's not that, and I'll talk more about this, not that that these racial differences are due to differences in socioeconomic status. There is something intrinsic about race and ethnicity that is leading to these differences in healthcare. So I'm going to talk about some of those inequities. So I thought, I'd bring it up to date, right? How are we doing in terms of COVID? So the graph on the left shows vaccination rates in Chicago neighborhoods comparing vaccination rates in Streeterville, which is a overwhelmingly white neighborhood, and vaccination rates in Englewood, which is an overwhelmingly Black neighborhood. And as you can see, there's a huge difference in vaccination rates between those two groups. And again, I want to make the point, I don't think this is because of overt racism among the vaccinators. I think that there are a number of issues that come into play here, some of which are on the healthcare provider side and some of which are on the recipient side, but regardless, it is racism that is driving this issue. On the right side, you see a graph that shows receipt of monoclonal antibody among almost 2 million Medicare recipients. And again, you see this big difference between receipt of the monoclonal antibody among those who are eligible for it, between whites and Blacks. And again, I don't think that this is because of overt racism. I think that there are issues at play here that are colored by racism that make these differences in the way that we treat our white and Black patients differently. I'm sure you all know that we have these race-based algorithms, and I want to go back to the point that race is not biology. If race is not biology, then these race-based algorithms really are, there's no basis for them, but we have them. So like there's the creatinine clearance correction. You all know about this, that the GFR for Black patients is multiplied by somewhere between 1.16 and 1.21 of the standard eGFR, because presumably, and there's some very, very shaky science that this is based on, that Blacks have higher muscle mass and creatinine generation rate than patients of other races. As a result of that, it is possible that Black patients, because they're thought to have a higher GFR for any given creatinine, will have delayed dialysis transplant referral, despite the fact that Blacks have a higher rate of end-stage renal disease than do whites. BMI estimations. So Asian patients are considered to be at risk for diabetes at BMI levels that are lower than patients of other races. And again, based on some pseudoscience, that Asian patients have more visceral than peripheral adiposity than patients at other races for similar BMI levels. And as a result of this, Asian patients may be subjected to unnecessary testing and treatment for diabetes. And then finally, and again, and there's like 15 of these race-based algorithms that we use regularly in medicine. So this is just a small sampling. You know about the correction for spirometry. The reference values for PFTs are adjusted for race and ethnicity, adjusted down. And this is based on some, again, so shaky data, including there's a study done in New Orleans in the 1970s. It was done at or Louisiana, done at among workers at an asbestos factory in Louisiana, where they estimated or measured lung function and noted differences between the Black workers and white workers. It's important to note that they did not account for things like smoking history and exposure to environmental pollutants in their study, but just sort of took the raw data on its face and found that there was these differences. And because of this, there may be increased difficulty obtaining disability support for lung disease. So then there's a bunch of these, vaginal birth after C-section, et cetera, et cetera, et cetera. Again, positing that race is biology, and therefore we should be making adjustments for differences in race in these algorithms. Well, how about if we just use race neutral policies? That should be colorblind and shouldn't have any racist effects. Well, here are some ways that this doesn't work very well. So for many organ transplants, eligibility criteria have, at least in part, to do with patients having sufficient caregiver support to be eligible for a transplant. Now, the problem with this is that individuals of color tend to work longer hours for equivalent pay, so they're not going to have as much time for caregiver support. They have less access to paid leave, and often higher incarceration rates due to inequities in our justice system. So the Black candidates and other persons of color are disproportionately penalized when on the transplant list. The Center for Medicare and Medical Services penalizes hospitals for excess readmissions. The patients from disadvantaged neighborhoods, which are going to be overwhelmingly people of color, are more likely to be readmitted after hospitalization for a number of reasons. And because of that, those hospitals may be penalized because they are mostly serving Black and other persons of color. And as I'm sure you know, in the early stages of COVID vaccine strategies, we targeted individuals who are 65 and older, but COVID mortality rates for Black patients just below that cutoff are actually 4 times higher than mortality rates for whites above that cutoff. So lower risk white residents were getting vaccines before higher risk Black residents. How about radiology? I mean, they can't even see skin, so there can't be anything going on there, right? So no. One study found that minority women who were ultimately diagnosed with breast cancer were 17% more likely than white women to have had a lesion missed on a prior mammogram within the preceding 2 years. And again, there are probably lots of reasons for this, like Black women getting mammograms done at facilities which have older equipment, or where people who are reading the mammograms aren't as skilled as reading them as the ones who are reading mammograms for white patients, whatever. But the reality is that this difference persists. And among individuals with lung cancer, almost 2/3 of Black smokers were ineligible for screening, compared with less than half of white smokers. So even in radiology, we can't even see skin. We see these differences in healthcare. Well, maybe race is just a surrogate for socioeconomic. I mean, we don't like talking about race, so maybe we can just talk about socioeconomic status and use that, because isn't race just a surrogate for that? Well, it's not. So from MMWR, we all know that Black women have higher mortality rates related to pregnancy than do white women. In fact, Black women with college degrees have much higher mortality rates than white women who have less than a high school diploma. So this is not just socioeconomic status. And in a study where they actually try to use socioeconomic status in the form of, there's an area deprivation index to account for differences in severe COVID-19 infection between races, there were still differences even after making this adjustment. So again, race and ethnicity are in and of themselves factors for our differences in healthcare inequities. This is not a representation of socioeconomic status by itself. Well, maybe we can just get the computers to do our work for us, right? Take the humans out of the equation entirely. So this is a study. There's a algorithm that is used in a lot of hospitals to identify patients for a high-risk management program after admission. And this is a study of over 50,000 patients who were admitted to a large academic hospital to use that algorithm. And this algorithm assigns scores to patients and then decides whether or not they're eligible for this added benefit based on their total healthcare costs accrued in 1 year. So the graph on the left shows the number of active conditions there on the y-axis and correlated with their algorithm risk score. White patients are in the sort of orangish line, and the Black patients are in the purple line. And as you can see, for any number of active chronic conditions, Black patients will have a lower score and therefore will be less likely to be referred for this added benefit than with white patients. And the reason for this is shown on the graph on the right, which is that for any number of chronic conditions, Black patients are less likely to will accrue fewer hospital costs than will white patients. And again, probably lots of reasons for this, like they don't want to go into the hospitals because they're afraid of what might happen to them here, or they might have access getting into the hospitals or whatever. But again, this is all, I believe, because of our institutional and structural racism that is woven into the very fabric of our society. Now, I want to talk about redlining. So again, it's not sort of obviously clear how this has to do with what we're talking about, but I want to, I think it's a really important point. So a study done fairly recently showed that among the 500 largest cities, 56 of them had life expectancy gaps between census tracts, so in the same city, but life expectancy gaps of 20 years or greater, with Chicago being the greatest at 30 years. And large life expectancy gaps occurring most frequently in cities that have higher levels of racial and ethnic segregation. Again, a lot of that is based on our redlining history, with average segregation scores among the 5 cities with largest life expectancy gap being 5 times higher than the average segregation score among the 5 cities with the smallest life expectancy gaps. And Black adults who lived in historically redlined areas had a lower cardiovascular health score compared to Black adults residing in the green neighborhoods. So again, just being in a red line neighborhood has pretty significant deleterious health effects. There are all sorts of issues that you probably know about in areas that are historically segregated. You know, there's food deserts and poor access to exercise and et cetera, et cetera, et cetera. And I want to give you some data that may be sort of close to home. Now, there actually is no red line map, at least that I could find, for Morgantown. So this is the next best thing. This is for Wheeling. So this is the red line map for Wheeling. And there is a score put together by the CDC called a social vulnerability score, which basically talks about how a neighborhood would be able to respond in the event of a health emergency. And it has to do with things like education and employment and language spoken. And so this is a social vulnerability index for Wheeling. And there are 2 areas I've highlighted here. These are areas from the red line map. So this area, this was in the green, and this red line map, and this was a red lined area on this red line map. So this is the green area, right? So this one on the red line map correlates with this on the social vulnerability index. And you can see that the life expectancy here is almost 80. This, the red line map, corresponding area on the social vulnerability index. This is what, I don't know, 3-4 miles maybe. Life expectancy is 10 years less. All right. Social vulnerability is a direct correlate to redlining. So where are we at with this? So this is a review done by David Acosta, who's the head of diversity for the AAMC, looking at racism in medical education and healthcare. And what they found, or what they determined, was that there are all these areas where racism raises its ugly head in our education and our healthcare system. In the interest of time, I'm not going to go over all of them, but just a couple of things I wanted to touch on. So again, misrepresentation of race in our curricula, biases in our hiring practices, salary inequities of our persons of color faculty in comparison to white faculty, and a toxic workplace environment on the medical education side. On the healthcare side, there's bias in clinical decision-making, interpretation of data, et cetera, et cetera. We talked about their race-based calculations and formulas, and systemic disinvestment in public and private sectors within Black neighborhoods. Switching gears a little bit. All right, so we've talked about medical education, we talked about healthcare. How about research? This is a study looking at funding from the NIH for R01 funds, and adjusting for all these things here that you would think would account for the likelihood that someone would get an R01 award. If you're Black, or if you're Asian, you were less likely to get funded than if you were white or Hispanic. And that hasn't gotten much better. This is data from 1995 till a couple of years ago. That basically funding for Black investigators through the NIH has been flat over the last 25 years. Does this make a difference in what we are funding? So this is different. This is funding for two diseases, one of which primarily affects what we consider to be white patients, and one of which affects primarily what we consider to be Black patients: sickle cell disease and cystic fibrosis. There are about 3 times as many people with sickle cell disease in this country than there are with cystic fibrosis. But I just want to have you pay attention to this column right here. This is the per person NIH funding. Per person, sickle cell disease only gets about 1/4 of the funding that cystic fibrosis does. So we had these conversations. We know that morbidity and mortality of whatever you can think of is higher in African Americans. And then we wring our hands and we say, I don't even know. Why is it? It's racism. I'm just going to say it out loud. It is racism. And again, I'm not talking about personal racism. I'm not even talking about institutional racism. I'm talking about cultural, systemic, ideological racism. It is all around us. The big question is, what can we do about this? No point in talking about this issue if there's not some solution to it. So this is a spectrum racism, and it goes anywhere from, I would kill a Black person just for being Black, I inflict fear on Black people, to this side. I expect the vast majority of us are somewhere over here, from awareness to allyship to maybe, this says here, abolitionist. Is basically the same thing as being anti-racist. And I think probably most of us are in here. And what I'd like to do is to have most of us try to move over to here. I will put my safety, health, and freedom on the line to fight for people of color. Because being not racist isn't enough. So it's important to understand the definition of racist, which we talk about. It's important for people to stop saying I'm not racist, because that really has no meaning. It is important for us to identify racial inequities and disparities. It is important to confront the racist ideas that you have held or continue to hold. Important to understand how your anti-racism needs to be intersectional, how race and our views on race intersect with our views on gender, on sexual orientation, on disability, on language. And finally, to champion anti-racist ideas and policies, because it's not enough in this racist society to be non-racist. We have, if we want to move forward, we have to be anti-racist. So again, from David Acosta, these are recommendations for anti-racist responses to systemic racism in our medical education and healthcare. Again, and then this will come up over and over again in the next couple of slides. The first thing is to understand, acknowledge, and reconcile our medicine's racist past, and commit to a shared vision for becoming equitable, inclusive, and anti-racist. Focus on building racial healing, trustworthiness, and relationships, and emphasize transformational change with system-based solutions. We need to try to move toward anti-racist pedagogy. And again, in the interest of time, I'm not going to go over all of this, but just very briefly, we need to standardize the language that we use to describe race and ethnicity, to get away from using terms like Asian or African American or Caucasian. We need to contextualize racial ethnic differences in disease burden and move away from attributing differences to biology and talk more about how social determinants of health inequities are important. And finally, we need to try to do our best to generate and impart evidence-based medical knowledge when it comes to race. There are a couple of institutions that have already adopted some anti-racist countermeasures. So UCSD has adopted these measures to try to address differential attainment among their students, changes in their curriculum. And again, I won't go over this in the interest of time, but changes in the curriculum to incorporating a theme of social justice, designing the process to revise the panels that they use, examples and standardized patients. Their assessment and grading, so mandating the use of grading committees in all core clerkships and restricting the amount of weight afforded to exam scores in the grade assignments. Looking at their faculty, implementing small group coaching programs of faculty who have release time to engage with students, and intentionally recruit underrepresented medicine faculty to medical school and educational leadership roles. And finally, evaluating their programs include race, ethnicity, and gender-based evaluations of assessment and grading in all core clerkships, and track student satisfaction and with education and career opportunities. This is a proposed anti-racism practice in a cardiovascular fellowship training, and this is specifically directed toward cardiovascular fellowship, but really can be applied to any, certainly internal medicine educational enterprise, and I think any medicine enterprise. Again, changing the curriculum, talking about the history of racism in medicine, our definitions of race and structural racism, clinical training, moving more toward community health experiences, engagement, and feedback, and a patient-centered experience, talking about our research, our methodology, journal club, and integrating equity into quality improvement, and finally using workshops. And I say workshops, these are not lectures. Lectures are they're fine and they're great for raising awareness, but you need to do workshops where people can get hands-on skills on dealing with things like microaggressions, framing anti-racism. This is a proposal for an anti-racist approach to clinical care. We talked about medical education. Now we're switching gears to clinical care. The components, learning the legacy of racism. Again, we're hearing a lot about that, right? It's important to learn the legacy of racism in American medicine. Admit to being racist, slowing down, identifying opposing racism at every level, and becoming involved in our communities. We need to switch gears from being race-based medicine to race-conscious medicine. We should avoid racially tailored practices that propagate inequity, talk about our racial health disparities that are consequences of structural racism, denounce race-based medicine, and change the way we do clinical research. And again, I'm not going to go over this, interest of time, but I'll make these slides available to you. An algorithm and how we can move from race-based medicine to race-conscious medicine. And then there are recommendations from the Massachusetts Medical Society for medical schools in Massachusetts on principles to achieve racial equity. And again, we're running out of time, so I'm just going to skip through these and get to this. I want to challenge you to think about what you can do, what you may be prepared to do, which may require some sacrifices to make some big changes. So Derek Bell is a law professor. He talked about civil rights law here, but it really applies to what we are talking about. The use of so-called neutral standards to continue exclusionary practices reduces the effectiveness of traditional civil rights laws while rendering discriminatory actions more oppressive than ever. Even those Herculean efforts we hail as successful will produce no more than temporary peaks of progress, short-lived victories that slide into irrelevance as racial patterns adapt in ways that maintain white dominance. Basically, what's saying is that if we persist in pursuing race-neutral policies, we aren't going to make any progress. And this from a recent article, because racism is a race-conscious system, redressing racial inequities requires race-conscious strategies. So at Brigham and Women's Hospital, they had done a study a couple of years ago demonstrating that people who got admitted for heart failure did better if they had better outcomes if they got admitted to a cardiology service than if they got admitted to a general medicine service. They then looked to see who was getting admitted to each service. And what they found here in red was that if you get admitted through the emergency room for heart failure, if you were Black or Latinx, you were more likely to get admitted to the general medicine service, again, associated with poorer outcomes than if you were white. Two of the co-authors of that study then wrote an article saying that basically what we are doing, again, our race neutral policies are not achieving the change that we need to see in terms of addressing health inequities. And they proposed a different system, which they called a healing arc. First was acknowledging, telling patients about our failures, and then to address redress in some way. And they proposed a whole different, many kind of ways that we can try to redress this. But the one that I bolded there, which I'll talk about in a minute, are race explicit protocol changes. And finally, to achieve closure, to work with our communities, to identify that we have addressed this issue and that we have solved the issue when that happens. What they have proposed, well, I shouldn't say proposed, what they are doing. So they have put into, they use Epic as their EMR, and they have these best practice advisories. So what they have put into place is that if a person of color is being admitted through the emergency department for heart failure, and the person admitting them wants to put them on the general medicine service, this warning will come up. It says this patient is from a racial or ethnic group with historically inequitable access to the cardiology service, you should consider changing their admission to cardiology unless there's a good reason to do otherwise. This doesn't tell you that you have to do this. It just says, here's our history. You should consider trying to address this history by doing something different than what you are planning to do. As you might imagine, this has provoked something of a firestorm of response. So this was about 6 weeks ago. There's actually an identified group of neo-Nazis who protested outside of Brigham Women's Hospital with this big sign saying that Brigham Women's Hospital kills whites. The co-authors of that study that I told you about have gotten death threats to the point where they need security details, gotten all sorts of vitriol even from other physicians about their ideas, but they are moving forward with it. So I'll leave you with this. So again, from Ibram X. Kendi, the only remedy to racist discrimination is anti-racist discrimination. The only remedy to past discrimination is present discrimination. And the only remedy to present discrimination is future discrimination. I thank you for your attention.
Thank you, Dr. Townsend. It looks like we have a comment and question in the chat here.
Sure.
Thank you for this crucial discussion regarding racism in medicine. We know that historically Black colleges and universities produce 80% of US Black nurses, yet receive little NIH funding. Do these colleges and universities, schools of medicine fare better?
I didn't catch the last part. We're asking if medical schools have the same issue that nursing schools do? Was that the question?
Do the historically Black colleges and universities, actual schools of medicine associated with them, do they fare better?
Well, I don't know the answer to that. That's a really good question. I don't know the answer to that. There's something that I will definitely look up. I would certainly hope that this is not another example of racial discrimination, but I can see, so when I did a similar talk a couple of weeks ago at another school, and someone asked a question, the NIH, because I showed that slide about cystic fibrosis and sickle cell disease, and someone said, the NIH, they're really strict about giving funding for things that they think are, going to be effective. And the problem here is that there's not a good animal model for sickle cell disease, while there is one for cystic fibrosis. And so that's really what the problem is. And I said in response to that, okay, that's fine. Okay, so there's not a good animal model for sickle cell disease. My question to you is, why is that? Why do we have a good model for cystic fibrosis and not for sickle cell disease? And maybe it's just difficulty with animal model for sickle cell disease, but we've got an animal model for HIV for a good 10, 15 years. And that's a disease that's only been around for 40 years now. Sickle cell disease has been around for hundreds of years. I should think that we'd have been putting more effort into developing an animal model if that's what is needed. And whether or not this is an example, again, of putting our blinders on and saying, okay, we need to just fund things that are going to work, and we don't have an animal model, so we're not going to fund cystic fibrosis. But the reason we don't have an animal model is we haven't put, it's sort of circular reason, right? We're not going to put money into funding something we don't have an animal model for. We don't have an animal model for it because we haven't put money into it. So sorry, it doesn't answer your question, but I think it is. I'll just say that I hope it is not the case.
Looks like another question from Dr. Hogan. How do you define person of color, and is this term useful?
Well, yes, I think it is useful. It's no matter what terminology you use, there are going to be people who have issues with it, and no term is going to be precise because we're not talking about biology. But it's sort of the best that we have. So my definition of person of color would be basically anyone who isn't white, and what is white? That's sort of how someone wants to define themselves. We can all talk about what white means, but person of color is anyone who is not white. So that would include Blacks, that would include individuals of Asian background, that would include individuals of American Indian background, Native Hawaiian background, et cetera. Any other questions?
Greg, I just wanted to thank you for this really important talk and making all of us, myself included, aware of so many nuances, I think, and that we tend not to think about in our practice with our patients and our lives. And I really thank you for that.
You're welcome. And I think, again, I hope that the message that came across is I'm not at all trying to sort of cast aspersions on us individually as healthcare providers, because I don't think that's where the problem is. I think the problem is society, and this is obviously, it's a bigger problem than we can fix right here. But I think we need to take that into account when we are dealing with our patients and with our communities, that there are issues much larger than themselves that are leading to the difference in which they access the healthcare system, which differences in the way that the healthcare system treats them. And we just need to try to keep that in mind.
We do actually have another question in the chat then. Dr. Regola says, much needed talk. Thank you. One question for you. As individual physicians, what can we do better to support our friends of minority groups? You mentioned moving to anti-racist. Could you describe some ways we can do this?
Yeah, so partly is going to be educating yourself. Among those would be, I think everybody should take the implicit association test. If you just Google implicit association test or unconscious bias test, you should take that. There's a whole bunch of them, including ones on race and gender and sexual orientation, but it can be very eye-opening for you to take the test and see whether or not, according to the test parameters, you have biases. I think that you should try to spend more time with persons of color, however you want to define that, whether they are your colleagues or people in the community or whatever. And that in and of itself is going to mitigate our unconscious biases. There are lots of studies demonstrating the more time we spend with people who are not like us, the less biases we're going to have for individuals in those groups. But it also can be an educational experience. And I don't mean, we ought to avoid doing things like, you as a Black person, can you tell me about such and such? Because Black people are not going to all think the same way about such and such. But just spending time with them and getting a sense of the kinds of issues that we are dealing with, I think is really important. And I will, again, make these slides available. I think there are lots of tips in those slides about how we can, as individuals and as institutions, move the needle forward in terms of being anti-racist. And finally, I would encourage you, if you haven't already done so, is to read the book on anti-racism by Ibram X. Kendi. It is absolutely powerful. There's also a great book, but not specifically about race, but a lot of it about race, called Caste by Isabel Wilkerson. I think they're both terrific sort of introductions to the problems that we have in society based on our race and our caste system. Any other questions? Thank you so much for your attention. Thanks for great questions. And I want to thank again, Dr. Fisher, for inviting me to be a part of this. It feels great to be back home. I haven't been back here in a couple of decades. Wow, things have changed so much, but it's great to be back. So thanks again for having me.
Thank you. Thank you.
Thank you. Great talk.
You're welcome.